Hello.
Hello, ma'am.
കേൾക്കാമോ?
കേൾക്കാം. സ്ക്രീനിങ് ആണ്.
എന്തായി എല്ലാവരും?
ഒരു 2 മിനിറ്റ് വെയിറ്റ് ചെയ്യോ? 8 വരെ ആയിട്ടുള്ളൂ.
2 മിനിറ്റ് വെയിറ്റ് ചെയ്യാം. എന്തായി? ഹലോ. ഹലോ.
ഹലോ മാം.
എത്ര പേരായി? നമുക്ക് തുടങ്ങാമോ?
ഒരു മിനിറ്റ് മാം. 35 പേര്.
നമ്മളാകെ 119 പേരുണ്ടോ? എത്രയാ?
119 മാം. ഇതിന്റെ കപ്പാസിറ്റി 100 വരെ ഉള്ളൂ. ബാക്കിയുള്ളവര് യൂട്യൂബിലായിരിക്കും. 117 ബാച്ച് കയറുന്നുണ്ടോ? അവര് വല്ലതും പറഞ്ഞായിരുന്നോ? ഇല്ല മാം, ഒന്നും പറഞ്ഞില്ല.
പറഞ്ഞില്ല അല്ലേ? ശരി, കുഴപ്പം. എങ്കിൽ നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. അപ്പോഴേക്കും ബാക്കിയുള്ളവർ വരുമായിരിക്കും.
ഓക്കെ മാം, സ്റ്റാർട്ട് ചെയ്യും.
So today we will discuss about orbit and diseases affecting the orbit. Orbit is the bony cavity in which the eyeballs are situated. That is the bony orbit. That is, it is the bony cavity in which the eyeballs are situated. The function of the orbit is protection of the eyeball, and orbit is has a larger volume than the eyeball, so that it can allow extreme degrees of ocular movements. The eye can move inwards, outwards, above and below because of the larger volume of the orbital cavity. And the main function is protection of the eyeball. The shape of the orbit is quadrangular truncated pyramid shape. A quadrangular, that is, it has a roof, floor, medial wall and lateral wall, and it has a apex and base. So you can imagine a truncated pyramid. The base is the anterior-most open part and the apex is the posterior-most part. Then it has roof, floor, medial wall, lateral wall. Each orbit is about 40 millimeter in height, width and depth. That is approximate measurement. There are 7 bonds which forms the orbit. That is, in the formation of the orbit, 7 bonds participate. These are, the roof is formed mainly by the frontal bond. In the posterior-most aspect, the lesser wing of sphenoid also, it also offers a small portion constituting the orbital roof. Then, the lateral wall is mainly by the zygomatic bone as well as the greater wing of sphenoid. And floor is mainly by the maxilla. Here you can see the picture. That is the roof mainly by the frontal bone. The posterior most end, there is the lesser wing of sphenoid. Then lateral wall is zygomatic bone and greater wing of sphenoid. And the floor is formed by the maxillary bone and the palatine bone. Posterior most part is by the palatine bone. And the medial wall, that is the frontal process of maxilla, then lacrimal bone, ethmoid bone, and a portion of the body of sphenoid that also forms the medial wall. These 4 bones constitute the medial bone. So altogether, there are 7 bones which forms the bony orbit. And coming to the applied anatomy, the medial wall is the thinnest wall. That is the lamina papyracea, that area, the ethmoid bone. That is the thinnest portion. So it gets frequently fractured during blowout fractures. That is, blowout fracture means a force like a blunt, like a fist or a cricket ball, which strike against the orbit, that will close the orbital outlet, so that the intraorbital pressure will increase and it will lead to fracture of the orbital bonds because of the pressure waves. That pressure cannot escape out. So that pressure will be dispersed inside the orbit, breaking the thinnest orbital walls. That is, thinnest portions are in the medial wall as well as in the floor. So these are the walls which gets fractured following various accidents or assault involving the face. Then inferior wall is involved in blowout fracture, and it is easily invaded by the tumors of the maxillary antrum. That is, maxillary tumors can invade into the orbital cavity through the floor of the orbit. And the lateral wall, the peculiarity of lateral wall is that it covers only the posterior half of the eyeball. So that is the area most vulnerable to the injury to the eye. That is, any force acting from the lateral aspect, it can injure the anterior most part of the eyeball because it does not cover the anterior portion of the eyeball. In orbital surgeries, like in orbital tumors, while we remove the tumors and all, an approach to the intraorbital cavity is easy through the lateral orbitotomy. That is, when you remove a portion of the lateral orbital wall, we can easily approach the posterior part of the orbital cavity. And coming to the orbital apex, here is the picture of the orbit. You can see a base of the orbit, that is the anterior most open part. Apex is the posterior most part. The orbital apex is the posterior most part where 4 orbital walls meet or converge. There are 2 orifices in the orbital apex. One is optic canal. Optic canal is the opening through which the optic nerve enters into the orbit so that it can reach the eyeball. So it transmits the optic nerve and the ophthalmic artery. Then comes the superior orbital fissure. That is the fissure between the greater wing and lesser wing of sphenoid. You can remember, that is, you have studied in anatomy. There is a gap between the lesser wing and greater wing of sphenoid. So that is known as superior orbital fissure. Certain important structures pass through the superior orbital fissure. That is a question in theory paper also. That is, draw the diagram of superior orbital fissure and label the structures passing through this fissure. So these structures include lacrimal, frontal, trochlear nerves, then superior and inferior divisions of the oculomotor or third nerve, nasociliary nerve, then abducens nerve, and superior and inferior ophthalmic veins. So usually you can remember it by the LFT obtained, no abnormalities detected. That is lacrimal, frontal, trochlear, LFT. Lacrimal and frontal nerves are branches of the ophthalmic division of trigeminal nerve. Then trochlear nerve is the 4th cranial nerve. So this lacrimal, frontal, and trochlear nerve pass through the outer aspect of the superorbital fissure. That is outside the annulus of Sinn. This red part is the annulus of Sinn. That is orbital fascia condensation in the orbital apex, which gives origin to the extraocular muscles like recti muscles. So outside that passes the lacrimal, frontal, and trochlear. Then inside that, that is medial to that, there is superior and inferior divisions of the oculomotor, that is third nerve. Then abducent, that is sixth nerve. Then nasociliary, that is also a branch of the ophthalmic division of trigeminal nerve. So these important structures pass through the superior orbital fissure. So you should learn to draw the diagram of this fissure. Then superior and inferior ophthalmic veins. Sometimes the inferior ophthalmic vein pass through the inferior orbital fissure. In some cases, it passes through the superior orbital fissure also. Then orbital fascia, that is a thin connective tissue membrane which covers the orbit. Then it condenses to form various dense membranes within the orbit, like periosteum covering the orbit, then Tennant's capsule, etc. So condensation of this orbital fascia forms Tennant's capsule, which covers the sclera. Then muscular sheath, which covers the recti and oblique muscles. Then intermuscular septum, that is the sheath separating the or connecting each recti muscle. Then suspensory ligament of Lockwood is the condensation of orbital fascia just below the eyeball, so that it forms a support to the eyeball, and also it condenses to form the periosteum and all. Then coming to the surgical spaces of orbit, this is also important. You will be asked to draw the diagram, or 1 mark question is usually asked, mention 4 surgical spaces of orbit. What do you mean by surgical spaces is that these are self-contained spaces. That is, if you inject some medicine or local anesthetic into one space, that will remain within that, confined to that space only. It will not spread to the other areas of the orbit. Or if there is an infection forming abscess, that abscess will be confined to that particular space, so that we can put an incision into that space and drain out that pus. So there are 4 surgical spaces which are relatively self-contained spaces. One is subperiosteal space, that forms the space between bone and the periosteum. Next is the peripheral space. So you can assume the 4 recti, superior, inferior, medial and lateral recti, taking origin from this annulus of Finn, they come anteriorly to get inserted into the sclera. So that, and there is a fascia connecting these 4 recti muscles. So that forms a closed space. One space is outside this recti, one space is inside the recti, within the recti muscles. That is within the space formed by the 4 recti muscles. So that space, the central space is the space within the muscle cone. Peripheral space is the space outside the muscle cone. That is a space, peripheral space is between the periosteum covering the orbital bones and the 4 recti with intermuscular septum. That is the peripheral space. Central space is the space enclosed within that 4 recti and the intermuscular septum. Then another space is subtenant space. That is the space between the sclera and the Tennant's capsule. So don't forget this. That is, there are 4 surgical spaces of orbit. One is subperiosteal space, peripheral space, central space, and subtenant space. So here you can see the eyeball and the attached recti muscles coming from the orbital apex to get inserted into the sclera. Actually, there is a septum, intermuscular septum, that is facial condensation connecting these recti muscles, so that there is a space within that muscle cone, outside that muscle cone. And coming to the diseases affecting the orbit, any space occupying lesion within the orbit can push the eyeball forwards, so that the eyeball is pushed out of the orbital cavity. That condition is known as proptosis. So proptosis is forward displacement of the eyeball beyond the orbital margins. We use the terminology exophthalmos, that is for describing prominence or proptosis secondary to thyroid disease. That is, in thyroid diseases like thyroid, it can be either hyperthyroidism, hypothyroidism, or euthyroidism. But in thyroid diseases, there can be associated orbital, the hypertrophy of the orbital tissue and all, and that can produce a orbital eye disease that will produce prominence and protrusion of the eyeball. That is known as exophthalmos. So exophthalmos is actually proptosis when it occurs in thyroid eye disease. So So how will you know whether the eye is proptosed or not? So you have to know what is the normal position of the eyeball. Normal position of the eye is such that if you place a ruler or a scale vertically touching the superior and inferior orbital margins, it should just touch the eyeball over the closed eyelid. That is, you place a scale or a ruler vertically touching the superior and inferior orbital margins. Then ask the patient to close the eyelid. That scale will just touch the eyeball over the eyelid. If there is proptosis, you cannot touch both superior and inferior orbital wall over the eye. That is, eyeball will be pushed out of the orbital margin. That is proptosis. So there is a clinical method to assess this proptosis. That is to know whether the eye is proptosed or not. That is in unilateral cases. If one eye is normal and the other eye is proptosed, how will you know which one is a proptosed eye? For that, you have to stand, ask the patient to sit on a stool, and the examiner should stand behind the patient, holding the patient's face between both hands of the examiner. That is, you imagine that is the doctor is standing behind the patient, he is standing, but the patient is sitting on a stool. Then place both hands on either side of the cheek, either side of the head of the patient, and gently elevate the head, gently elevate the neck. That is just push the head backwards, so that, and look over the head of the patient. If you see one cornea ahead of the other, ask the patient to look straight ahead. But when you just slowly elevate the head, what happens is you can see the apex of the cornea. If normally both corneas should be seen simultaneously. If one cornea is seen ahead of the other, that eye is proptosed. This clinical method of examination is known as Nafziger's method of examining proptosis. Nafziger's method. Then there are certain instruments used for measuring proptosis. This instrument is known as exophthalmometer. This is an example, Hertel's exophthalmometer. That is, you can place the edges over the lateral orbital rim of both orbits, and the apex of the cornea will be reflected on a mirror, and you can just measure the distance from the lateral orbital rim to the apex of the cornea, and you compare it either with the normal value or with the normal eye. If both eyes are proptosed, you can assume that about 21 millimeter is the upper limit of a normal value. If it is more than 21, that is proptosis. But if one eye is proptosed, you can compare and take the difference as a proptosis. So that is it. That is, subjective assessment is by Nafziger's method. Patient is seated, surgeon standing behind him, holds the patient's head in such a way that he looks straight down the nose. Rotate the patient's head backwards until he can just see the apex of one cornea. If he sees the apex of one cornea earlier than the other, that eye is proptosed. Coming to the causes of proptosis. Usually, most common cause is any space-occupying lesion within the orbit. Less frequent causes are herniation of this contents of the. Before that, I can tell that the relations of the orbit. That is, above it is related to the anterior cranial fossa, below it is related to the maxillary sinus. So, in blood fractures of the floor of the orbit, the maxillary or any tumors arising from the maxilla, this maxillary tumors can invade the orbit. So that can itself produce a proptosis. Usually following blood fracture, what happens is the orbital contents protrude into the maxillary antrum, so that the orbital volume decreases and it will lead to enophthalmosis, that is opposite to the proptosis, inward displacement of the eyeball. But in tumors affecting the maxillary sinus, the tumor can extend into the orbital cavity, producing a proptosis. Or any herniation of the cranial contents is also known as proptosis. So common space-occupying lesions in the orbit. What are the common space-occupying lesions? Here, these lesions can be classified as either intraconal lesions, that is the lesions occurring within the muscle cone, this pore recti and the intermuscular septum, or Extracorneal means outside the muscle cone, that is within the peripheral space. So intracorneal lesions occur in the central space, extracorneal lesions occur in the peripheral space. So extracorneal lesions are dermoid cyst, rhabdomyosarcoma, then extension of the nasal or sinus diseases or tumors or infections, etc. Then intracorneal lesions are cavernous hemangioma, optic nerve glioma or meningioma, AV malformations, etc. Then other conditions which can be either intracorneal or extracorneal, that is muscular disorders like thyroid ophthalmopathy, pseudotumor or idiopathic inflammatory disease of the orbit, then cysticercosis, lymphoproliferative diseases of the eye. Then common causes for unilateral proptosis. If one eye only is proptosed, the common causes are orbital cellulitis, that is inflammation of the cellular tissue of the orbit. Then idiopathic orbital inflammatory disease or pseudotumor, and orbital venous thrombosis, arteriovenous malformations or AV aneurysms, tumors of the orbit and its contents, then orbital hemorrhage or emphysema. Emphysema is air escaping into the orbital cavity following fractures of the paranasal sinus wall, like fracture of frontal sinus, ethmoid sinus, sphenoid sinus. This air can escape into the orbital cavity, which will push the eyeball forward, producing a proptosis. That is known as orbital emphysema. Usually that is unilateral. Or orbital hemorrhage can also occur following some trauma. These are the causes for unilateral proptosis. All these can be used for you have to study this because these questions can be asked as 1-mark question. Mention 4 causes for unilateral proptosis, 4 causes for bilateral proptosis, etc. So orbital cellulitis, idiopathic orbital inflammatory disease, orbital venous thrombosis, AV aneurysms, tumors of the orbit and contents, then orbital hemorrhage or emphysema. Coming to bilateral proptosis. Common causes of bilateral proptosis are endocrine exophthalmos, that is the thyroid ophthalmopathy. Most common cause is thyroid ophthalmopathy in an adult patient. Then cavernous sinus thrombosis, that is when a thrombus occurs in the cavernous sinus, both orbits get affected. Then empyema of paranasal sinuses, symmetrical orbital tumors like lymphoma, leukemic infiltrations, metastasis, etc. Then some congenital anomalies of the head or cranial bones, diminished orbital volume as in optocephaly, etc. Then coming to causes of proptosis in children. The causes vary both in children and adults. In children, common causes for proptosis are tumors occurring in children. They are different from tumors affecting adults. That is, this congenital tumors, hereditary tumors, congenital tumors like dermoid, epidermoid cyst, then capillary hemangiomas, optic nerve glioma, rhabdomyosarcoma, leukemic infiltrates, metastatic neuroblastoma, plexiform neurofibromatosis, and lymphangiomas. So these are the causes for proptosis in children. Whereas in adult, the proptosis causes include metastasis from breast, lung, and GIT, cavernous hemangioma, then mucocele of the frontal sinus or ethmoid sinus, lymphoid tumors, then meningiomas. So from the tumors affecting optic nerve glioma occur in children, whereas optic nerve sheath meningioma occur in adult. Similarly, from the vascular tissue, the cavernous hemangioma occur in adult, whereas capillary hemangioma occur in children. Then this neuroblastoma, nephroblastoma, metastasis occur in children only, whereas metastasis from breast, lung, and GIT usually seen in adult. Then usually proptosis is a gradually progressing one, whereas in some cases there can be an acute occurrence of proptosis. So what are the causes for acutely presenting proptosis? One is orbital emphysema following fracture of the paranasal sinus, following road traffic accident or any other injury. Then orbital hemorrhage that can present as an acute proptosis, or spontaneous rupture of an ethmoidal mucocele that can also present as acute proptosis. Then usually proptosis can be a constant proptosis or an intermittent proptosis. What are the causes for intermittent proptosis? Intermittent proptosis can be seen in orbital varices. In varices, there is varying dilatations of the orbital veins, and on bending down position, because of the gravitational effect, there can be an increase in proptosis. Then periodic orbital edema can produce intermittent proptosis, recurrent orbital hemorrhage, spontaneous hemorrhage, as in hemophilia and all, that can produce intermittent proptosis, or highly vascular tumors can also produce intermittent proptosis. Then pulsatile or pulsating proptosis, you will get a pulsation. That is usually seen in carotico-cavernous fistula. That is a communication between internal carotid artery and the cavernous sinus. That can produce a pulsation, pulsatile proptosis. Then saccular aneurysm of the ophthalmic artery can also present as pulsatile proptosis. These are true pulsations, whereas in certain cases, transmitted pulsations can be seen. That is, from the cranial cavity, the pulsation, cerebral pulsations get transmitted to the orbital cavity through a deficient orbital roof, as in congenital meningocele, neurofibromatosis, and traumatic or operative hiatus of the orbital roof. When the orbital roof is deficient, the cerebral pulsations get transmitted. So that is transmitted pulsation. The true pulsations are seen in carotico-cavernous fistula and saccular aneurysm of the ophthalmic artery. Then, even though all these space-occupying lesions can produce proptosis, usually intracornal lesions will produce an axial proptosis. Axial proptosis means the eyeball is pushed out straight ahead. There is no upward, downward, or lateral deviations. Whereas eccentric proptosis is, in addition to the forward movement, there is a sideways movement also. Either it is deviated outwards, inwards, upwards, downwards, and all. So that is known as extracornal. That is known as eccentric proptosis. Axial proptosis are produced by intracornal lesions, and eccentric proptosis is produced by extracornal lesions. So, intracornal lesions and extracornal lesions. Then proptosis due to hemopoietic tumors like leukemia, lymphoma. Then rhabdomyosarcoma and neuroblastoma progresses rapidly. Usually, this type of proptosis progresses rapidly. Then, what are the other clinical features associated with an orbital disease other than this proptosis? So, in addition to proptosis, there can be restricted ocular movements. Because of the mass lesion, the ocular movements get restricted. That will lead to diplopia or double vision. Then, because of the pressure effect on the optic nerve, there can be edema of the optic nerve head. That is known as disc edema. If it is bilateral, that is papilledema. Then, optic atrophy. Optic atrophy is long-standing pressure on the optic nerve can produce optic atrophy. Usually, when it occurs because of the pressure effect on the optic nerve, we call it as disc edema only. When it is due to an elevated intracranial pressure only, we use the term papilledema. That you should remember. It can be in orbital diseases, it produces actually optic disc edema, not papilledema. Papilledema is usually reserved for the type of disc edema due to raised elevated intracranial pressure. Then what is enophthalmosis? Enophthalmosis is inward displacement of the eyeball. Inward displacement. That is usually due to severe injury in which bones of the orbit usually due to severe injury in which bones of the floor of orbit are fractured and the soft tissue herniate into the maxillary sinus. That is, I have told earlier that when there is a fracture of the floor of maxillary sinus, what happens is the orbital contents get herniated into the maxillary sinus. So, there is a loss of orbital volume. Then the eyeball can fall backwards. That leads to inward displacement of the eyeball known as enophthalmosis. So, enophthalmosis is inward displacement of the eyeball, usually due to severe injury in which bones of the floor of orbit are fractured and soft tissue herniate into the maxillary sinus. It may also be the result of some orbital cellulitis, resolved orbital cellulitis, which is followed by fibrosis and mechanical retraction. That is fibrosis of the orbital contents, retraction leading to a falling back of the eyeball. Then paralytic enophthalmosis is seen in sympathetic palsy, that is Horner syndrome. Then another cause of enophthalmosis include due to atrophy of the orbital contents like senile due to old age. In old age, sometimes the orbital tissues undergo fat get lost and there is loss of fat and atrophy of the orbital contents leading to an enophthalmos, or following irradiation in the orbital area, or cicatrizing metastatic carcinoma, cicatrizing type of metastatic carcinoma. Then scleroderma, all these are causes for enophthalmos, that is inward displacement of the eyeball. Here you can see in the left eye, there is a slight inward displacement. Then how will you investigate a case of orbital disease? So we have discussed about clinical features of the orbital disease like proptosis and all. Now, what are the investigations of orbital lesions? There are 3 stages of investigation. One is imaging of bony structures by plain X-ray, then imaging of soft tissues by CT scan, ultrasound scan or MRI, then demonstration of the orbital vasculature by orbital angiography, venography, carotid angiography, digital subtraction angiography or MR angiography, which can reveal some vascular causes like AV malformations, orbital varices and all. So in plain X-ray, nowadays we are not using plain X-rays usually. We are not using plain X-ray because anyway CT scan of the orbital area gives more information than plain X-ray. But the plain X-ray PA view can be used to see calcification or hyperostosis, which occurs in orbital meningioma, optic nerve sheath meningioma, the lateral view for intracranial lesions, Waters view in blowout fractures, and special views for optic foramen. That is, when you see, if you want to see some lesions in the optic foramen, there is a view known as optic foramen view. In that view, we can see the dilatation of the optic foramen or an enlargement of the superorbital fissure in lesions affecting that area. So nowadays, we are not relying on the X-ray findings, only we do CT scan straight away. So orbital X-ray also shows some radiopaque lesions. In orbital ultrasonography, that requires probe functioning at a lower speed to allow greater penetration into orbit, generally 5 MHz. So using ultrasound, we can get an idea of the soft tissue lesions and the details about muscular enlargement as occurs in thyroid ophthalmopathy, whether it is only tendon sparing enlargement, that is only the muscle belly is enlarged or the entire muscle is enlarged as in pseudotumor. So all these can be differentiated by the ultrasonography. Then coming to CT scan. CT scan is an important investigation in orbital diseases. The fat in the intraconal space acts as a natural contrast medium. So CT scan is an accurate method of orbital diagnosis when soft tissues are involved. It helps to detect the anatomical extent of the space occupying lesion and the type of the tissue affected, and it can delineate the margins and whether it is possible to do a surgical excision of that lesion and all. So before doing any orbital surgery, CT scan is a must. Here you can see CT scan finding showing cavernous hemangioma, that is an intraconal lesion. Intraconal means within the muscle, that is intraconal lesion. So on the right side, that lesion, after taking out a gross lesion histopathology, for taking histopathology, that is a gross lesion, gross pathology. And coming to MRI, MRI is superior in delineating the space occupying lesions affecting soft tissues rather than bony lesions. So it generates high resolution images without using ionizing radiation. But that is the advantage. Here there is no ionizing radiation, so safe in children or pregnant ladies and all. But it is contraindicated if you suspect a metallic or magnetic foreign body. MRI is better for soft tissue lesions, while CT is preferred for bony lesions. Here you can see the MRI. Then coming to angiography, it is required for patients with vascular anomalies like AV malformations, arteriocarotid cavernous fistula, indirect carotid cavernous fistula, or vascular tumors to identify the feeding vessel before doing any surgery. Then digital subtraction angiography and MR angiography are 3-dimensional and provide detailed information, especially about the vascular malformations in the orbit. That is digital subtraction angiography and MR angiography. So these are, today we have discussed about the anatomy of the orbit, then the very clinical features that occur in various diseases in affecting the orbit, mainly proptosis and other clinical features, and how will you investigate a lesion occurring in the orbit. So I think today we can stop the class. Tomorrow we will continue. So in a nutshell, today we have discussed about the anatomy. The importance is the anatomy. The bony orbits are truncated pyramids. It has a base, apex, and 4 walls. You should remember the 7 bonds which form the orbit, which are the 7 bonds. Then what are the structures passing through the orbital apex, through the optic foramen as well as the superior orbital fissure. Then what are the condensations of orbital fascia? Then which are the 4 surgical spaces of the orbit? That is periosteal space, peripheral space, central space, and subtenon space. Then coming to the clinical features of orbital disease, the most important of which is proptosis, that is forward displacement of the eyeball beyond orbital margin. So for that, you have to know what is the normal position of the eyeball. That is, when you place a ruler touching the superior and inferior orbital margin, it should just touch the closed eyelids. Then subjective assessment by clinical assessment of proptosis is by Napsiger's method. Then by using instruments, we can use Hertel's exophthalmometer for measuring the amount of proptosis. Then Hertel's is the exophthalmometer that is used for measuring the proptosis. Here you can see the Hertel's exophthalmometer. Then coming to causes of proptosis, that is common causes are space occupying lesions in the orbit. Other causes include herniation of tissues from the maxillary sinus as well as anterior cranial fossa. Then what are extracorneal lesions which produces eccentric proptosis? What are the intracorneal lesions which produce axial proptosis? Then unilateral proptosis, what are the causes? Then bilateral proptosis, what are the causes? Then causes of proptosis in children, causes of proptosis in adult. Then which are the causes which produce acute proptosis? Which are the conditions which produce intermittent proptosis or pulsate? Then other conditions producing pulsating proptosis. Then what is enophthalmos? What are the investigations we have to do in orbital diseases? Then in the next class, we will discuss about each condition in detail, like orbital inflammatory disease. Then what is orbital cellulitis? What is thyroid eye disease? Or which are the tumors affecting the orbit? All this can be discussed in the next class. Any doubts? Leah?
No
Hello?
doubt, ma'am. Hello, ma'am.
Clear ആയോ? പറഞ്ഞോ.
Clear.
ക്ലിയർ ആയി. അപ്പൊ നാളെയും നമുക്ക് ഇതേ സമയം 6 മണിക്ക് ക്ലാസ്.
6 മണി. Okay, ma'am.
6 മണിക്ക് ബാക്കി എടുക്കാം. അപ്പൊ കണ്ടിന്യൂസ് ആയിട്ട് പോകും. ഇന്ന് തന്നെ നിങ്ങൾ എല്ലാവരും പോയി വായിക്കുക, ഓർബിറ്റ് വായിക്കുക. ഇന്ന് തന്നെ വായിച്ചാൽ കുറച്ചും കൂടെ നിങ്ങൾക്ക് മനസ്സിലാവും കേട്ടോ. ഈ ക്ലാസ് കഴിയുമ്പോൾ തന്നെ ഓർബിറ്റ് ഇന്ന് എടുത്ത ഭാഗം വായിച്ചാൽ കുറച്ചും കൂടെ മനസ്സിലാവും. അപ്പൊ ശരി. ഓക്കെ. എത്ര അറ്റൻഡൻസ് ഒക്കെ ഇന്ന് എത്ര പേര് കയറിയായിരുന്നു അറിയോ?
മാം സൂമിൽ ഇപ്പൊ 69 പേരുണ്ട്. കുറച്ചുപേര് യൂട്യൂബിലുണ്ട് മാം.
യൂട്യൂബിലുണ്ട്. അപ്പൊ എനിക്ക് അറ്റൻഡൻസ് തന്നിരുന്നാ മതി.
ഞാൻ അയച്ചേക്കാം.
ശരി. ഓക്കെ.
താങ്ക് യു മാം.